I have MS, but you wouldn't know by looking at me. Many MS symptoms can be invisible to people around you or hard to notice.
Multiple sclerosis is an immune-mediated inflammatory disease of the central nervous system. It involves the formation of lesions within the white and grey matter of the CNS. This interferes with the nerve impulse transmission throughout the brain, spinal cord, and optic nerve through the progressive demyelination of oligodendrocytes, the cells responsible for maintaining the fatty myelin sheath surrounding nerves, by forming cholesterol crystals resulting in axonal injury and loss. This disrupts the nervous system's ability to effectively communicate, leaving the patient with significant physical and cognitive deficits. This is likely to be an immune-mediated response, whereby the presentation of a foreign antigen, which breaches the blood-brain barrier and enters the CNS, activates a systemic immunological response by macrophages including the B and T cells. At present, there is no definitive cause of MS and no one specific test for its diagnosis. It is typically diagnosed based on presenting signs and symptoms in combination with clinical imaging and pathology. There are four main disease causes of MS. Clinically isolated syndrome is the first episode of inflammatory demyelination of the CNS and results in acute symptoms. The typical age of presentation is between 20 and 30 years. Around 70% of these patients will follow a relapsing remitting pattern in which partial or total recovery from the exacerbation occurs. In most cases, this proceeds to secondary progressive MS, where only partial recovery occurs, and primary progressive MS is less common but describes a gradual course of deterioration with or without limited remissions from the onset of the disease. MS presentation can be categorised into objective signs and subjective symptoms. Firstly, gait abnormalities is one of the first most observable signs, characterised by the patient's inability to stand upright, a changed style of walking, and a dropped foot appearance due to ankle weakness, making it difficult to lift the front foot, causing it to drag along the ground. Paresthesia is the invisible sensory symptoms, which includes tingling, numbness, and burning sensations, which are felt in localized areas of the CNS or diffused throughout the body on one or both sides of usually the face, body, arms, legs, and less commonly the genitals. It impacts movement and fine motor skills. Optic neuritis describes the acute inflammation and demyelination of the optic nerve. It disrupts the images transmitted from the retina to the brain, causing blind spots, areas of poor vision and blurring, colour blindness, uncoordinated eye movements, and a sharp knife-like pain sensation behind the eyeball. It usually occurs suddenly in one eye and progressively worsens.
For me, one of my eyes will twitch in a random direction, making me think there is something next to me. There never is.
Urinary incontinence and bowel issues, such as constipation, result from issues such as polyuria and decreased gastrointestinal peristalsis. As for dysphagia, it is defined as difficulty swallowing, which may result in aspiration of food and pharyngeal secretions. As for dysphonia, it is a voice disorder which prevents the patient from saying a word and not being able to talk at all. As for patient symptoms, spasming is an unexpected stiffening of a muscle causing it to jerk out or towards the body. Spasms predominantly affect the biceps, quadriceps, and hamstrings. As many as 90% of patients report spasticity symptoms at some point in their disease progression. Increased heat sensitivity may also occur due to MS lesions dominating the hypothalamus. Heat slays down the messages passing along nerves and gives rise to increased symptoms such as fatigue, blurred vision, loss of balance, the inability to concentrate, and memory loss. Up to 90% of patients report to have experienced acute episodic periods of pain and severe chronic pain. It may be divided into neuropathic, also known as nociceptive, and musculoskeletal pain. Neuropathic pain includes symptoms of neuralgia, peripheral neuropathy, weakness, numbness, sciatica, and intense sensations in the side of the face. Musculoskeletal pain is caused by damage to the muscles, tendons, ligaments, or soft tissue. Common complaints with MS patients include hip and back pain due to an altered walking style, muscle stiffness, and spasticity. Lermans sign is the phenomenon that describes electric shock feelings in the midline trunk that radiate to the limbs. Also, the MS hug is used to describe a feeling of chest pain, tightness, and a subsequent shortness of breath associated with inadequate brain signals regulating the respiratory system. As for cognitive symptoms, these include memory loss, fatigue, and serious depression and anxiety. MS can result in moderate to severe depression, frustration, and anxiety as a result of patients' feelings of inadequacy, being dependent on others, adjusting to lifestyle changes, and lack of control. Associated behavioural and physical symptoms, including changes to sleep, appetite, energy level, concentration, socialisation, and self-esteem, as well as an increased heart rate, blood pressure, respiratory rate, and diaphoresis, result in long-term acute symptoms having a profound effect on the body.
Avonex is an injectable treatment for the symptoms of relapsing remitting and secondary progressive MS. Dosage starts at a quarter of the whole amount, but by the fourth injection works up to the full amount of 30 micrograms per week via IM. It is contraindicated in allergies, suicide or depression, as risks increase in interferon use, and pregnancy, as the effects are unknown. Side effects are extensive, including malaise, night sweats, nausea and vomiting, extremity pain, insomnia, rash, dyspnea, general pain, fever, chills, and myalgia. Almost enough to deter you from wanting to take Avonex. Let's talk about medication class. It is an interferon beta 1A, and interferons are cytokines which maintain the immune system in response to biostimuli. There are three major types: alpha, beta, and gamma. Its action is to bind to specific receptors on cell surfaces, then destroying invading cells through natural cell cascade actions. Generically known as natalizumab, falls under the therapeutic class of monoclonal antibody therapy, monotherapy for the treatment of RRMS to delay progress and reduce relapses. Recommended dosage is 300 milligrams diluted into 100 ml of normal saline via IV infusion every 4 weeks. It binds to the surface of leukocytes, which then inhibits them from binding to counter receptors, further inhibiting them from endothelial migration into inflamed tissue, therefore reducing damage but increasing the number of circulating leukocytes. It is contraindicated in those that are allergic, those that are immunocompromised, and people using immunomodulatory meds like Avonex. Some adverse effects include headache, fatigue, joint pain, nausea and vomiting, pyrexia, and risk of UTI and lower respiratory tract infection, as well as depression and something called PML. Most people have a dormant state of the JC virus. It becomes active when the immune system is weakened, but chances of developing PML are slim. Tisabri can encourage PML development simply because it weakens the immune system. 3 main risk factors increasing the likelihood of PML include using Tisabri for 2 or more years, already having the JC virus, or using immunosuppressants prior to commencing Tisabri. Close monitoring by doctors is needed in order to deter PML, as there is currently no prevention, no treatment, and no cure. The only preventative measure is to cease treatment when signs arise. Some of these signs include progressive weakness, vision, speech, cognition problems, and mood, behavior, memory, and communication problems. Mavenclad, or cladribine, is a disease-modifying drug, which means it changes the disease unlike Avonex and Tisabri, which both modify symptoms and the frequency of relapse. Mavenclad reduces relapses compared to no treatment, and, once relapses do occur, they are less severe. It is used in RR and SPMS. It is taken in 2 courses. The first 2 years of treatment, dosage starts at 3.5 milligrams per kilo. This then halves after the first 2 years and continues as a 2-week treatment course. It is taken orally. The courses are both taken 12 months apart. Course 1, pills are taken 5 days in a row for a month, then another 5 in the next month. There's a break for 12 months, and then course 2 repeats the same process as in course 1. This reduces T and B lymphocytes, so monitoring is needed. Some adverse effects include risk of URTI and UTI, nausea, diarrhea, headaches, rash, and lymphopenia, as well as hair loss. Contraindications include people that are allergic, people with HIV, people with active chronic infections like TB, those that are immunocompromised, people with moderate to severe renal impairment, people with active cancer, and those that are pregnant or breastfeeding, even though it is not known whether Mavenclad interferes with fetal development or is transferred through milk. Mavenclad increases the chance of infection as it lowers the immune system. So, why can't people with HIV, chronic infections, those that are immunocompromised, and people with cancer take it? Well, what is Mavenclad? It's a biologic disease-modifying anti-rheumatic drug, or a BDMARD. This means it blocks specific immune system substances, T and B lymphocytes to be precise. When immunocompromised, one is at higher risk of secondary immunodeficiency due to the lowered immune system. People who are pregnant and breastfeeding cannot take it because there has not been enough testing. Because of this lack of knowledge, it is safest not to use it, just in case.
The management of MS aims to reduce acute attacks of inflammatory activity known as relapses and to improve the quality of life. Preventative strategies can also be used to reduce inflammation, to reduce axon loss and long-term disability. Underlying infections should also be identified and treated appropriately. Plasma exchange, or plasmapheresis, can be used for acute relapses of MS. Relapses cause significant functional damage and reduce quality of life. Plasma exchange involves a process whereby antibiotics and clotting factors are filtered from the plasma, then the patient's blood is returned to their circulation. There are several different management plans for each symptom relating to MS. Urinalysis tests may determine the cause of urinary dysfunction. Implementing a regular toileting schedule, a regular fluid balance chart to assess for fluid intake and output, an adjustment of fluid intake, for example, less than 2 litres a day, and avoidance of caffeine may improve these issues. A permanent suprapubic catheter insertion may be indicated in severe instances. Further consultation with urology specialists for testing and management of bladder dysfunction may be needed. Nursing management for bowel dysfunction includes dietary adjustments, maintaining perianal skin hygiene, abdominal massage and toileting schedules, as well as the use of stools charts, fluid balance and laxatives is required. Advanced MS patients with severe bowel problems may require the insertion of a colostomy. A full blood count should be ordered upon admission, along with a sleep study to assure that the fatigue is related to MS and not other coexisting conditions. Initially, management should be focused on identifying possible triggers to fatigue, including sleep disturbances, heat intolerance, mood disturbances, or medication reactions. This will allow for an individualized plan. For gait impairment issues, nurses should assess patients with a falls risk score and potential falls management plans. The management of immobility consists mainly of physical therapy. The use of mobility aids should be made available for patients. Examples of these aids include ankle foot orthosis, crutches, wheelchairs, and walkers. Environmental hazards should also be reduced. Nurses should ensure that the patient's room is free from trip hazards, and they should encourage the patient to utilize the call bell when in need of any form of mobilization for assistance. In terms of swallowing, a nasogastric tube may be required for patients with dysphagia. Nursing care will involve enteral feeding and adequate nutritional management. Supervised mealtimes should be implemented to reduce the risk of choking. Additionally, thickened fluids may be suggested.